It's a pleasure to introduce our distinguished speaker, Dr.Sara Awad. Dr. Awad completed her medical school from the University of Sharjah in the United Arab Emirates in 2011. Then she completed her Internal Medicine Residency Program at Queen's University in Kingston in 2015, and Endocrinology, Metabolism, subspecialty residency program at the University of Ottawa in 2017. She joined the Faculty of Medicine as an assistant professor in the Department of Medicine in 2017. Dr. Awad is passionate about medical education and completed Master of Health Professions Education at the University of Illinois at Chicago in 2021. Her medical education focus is curriculum development and developing self-regulated learning through personal learning plans in the context of competency-based medical education. Dr. Awad is a member of the Canadian Society of Endocrinology and Metabolism Section Planning Committee. Today, she will be sharing her experiences about managing side effects with focus on bone health. Welcome, Sarah, and thank you.
Hello, everyone. Good afternoon. I'm Sarah Awad. I am an academic endocrinologist at Queen's University, located in Kingston, Ontario, Canada. Thanks for the planning committee, and special thanks to Dr.Shaheen for inviting me to deliver this talk about bone health in patients with breast cancer. So just to tell you where I am, so this is where I work. This is the hospital campus located in Kingston, Ontario, on Lake Ontario. And this is the university campus that I also teach at the medical school. And this is literally the city that I live in. As you can see, the map of Canada is huge. So I'm in a small town called Kingston that is on Lake Ontario in the province of Ontario. My objectives today is to review the causes of bone loss in patients with breast cancer and to discuss bone health preventative and treatment strategies in patients with breast cancer. So we know that bone loss is common in patients with breast cancer, and bone metastases occur up to 73% in patients with this breast cancer population at some point during their course of their disease. As a result, optimization of bone health is a very important aspect to reduce the morbidity and that is associated with bone loss in this patient population. There is a lot of causes of bone loss in patients with breast cancer, but the two major causes that are specific to this patient population is the treatment-related bone loss. As we all know, estrogen is the hormone that drives the proliferation of breast cancer cells, and as a result, estrogen deprivation is one of the treatments in patients who have breast cancer. So includes adjuvant endocrine therapy like aromatase inhibitors, like letrozole, that is given to patients who are HER2 positive or postmenopausal. And also in premenopausal women who have breast cancer, we do cause them to have hypoestrogenemia by either doing bilateral oophorectomy or chemotherapy. In both cases, hypoestrogenemia is really the driving cause of further bone loss by increasing osteoclastic activity and increasing bone turnover. The other cause of bone loss in this patient population is related to metastases. And as we know, bone metastases is very common in breast cancer patients at some point, and malignant cells actually results in further stimulating the osteoclast, resulting in increased bone resorption. And that not only further leads to bone growth, but also further bone loss and increasing risk of fragility. Other causes that we know, like any patient population, so essentially older population, being Caucasian, so low bone mineral density is definitely a risk factor in general for bone loss and osteoporosis. Having personal or family history of fragility fractures, being postmenopausal, using steroids, previous history of osteoporosis, smoking, and other risk factors such as rheumatoid arthritis, or if the patient drinks a lot of alcohol, that's all risk factor to add to the bone loss on top of their breast cancer. Just to remind you of the normal bone remodeling cycle, and I'm just going to review it in brief. So essentially, we know that there's a balance between bone resorption and bone formation. And osteoclasts are the major cells that causes bone resorption, so essentially eating up the old bone. And osteoclasts are activated by the rank system, where the rank ligand binds to the rank receptor on osteoclasts, resulting in osteoclastic activity, which causes bone resorption. For this process to stop, there is osteoprotegerin, which is a hormone that will actually prevent this binding, and as a result, will kind of halt excess osteoclastic activity. And that will give a chance for the osteoblasts to take over and basically deposit in new bone and mineralize that bone using calcium and phosphate. So any disturbance in this normal balance system can result in bone loss. For example, low estrogen actually result in further decrease in osteoprotegerin, resulting in more increase in the rank ligand compared to osteoprotegerin ratio, resulting in further increased osteoclastic activity and more bone resorption than formation. How do these patients present? They can present with fragility fractures, vertebral and long bone from minimal trauma. They can have bone pain, not only because of their bone mets, if that exists, but that can indicate that they're having significant bone loss and maybe microfractures. They can have impaired mobility, especially if there's any compression fractures on their spine or spinal cord compression. If, again, they got a really diffuse compression fracture of their vertebrae, and that can cause spinal cord compression, and hypercalcemia. So as a result, it's very important that we look after the bone health in patients who have breast cancer. So who do we screen? Screening is similar to what we use to screen for bone loss in the general population. So we get a baseline bone mineral density using the DEXA scan. And remember that the DEXA scan will give you the quantity of the bone, not the quality. And that's why it has its limitation. So it's very important that when you make any decisions, you also take into consideration your clinical scenario. But it still works, and it's very helpful, especially also over time, to see trends and if treatments is working or not. It's very important to screen all premenopausal women who have breast cancer and had premature ovarian failure, whether it's because of surgery, chemotherapy, or luteinizing hormone, releasing hormone analogs, all of which will cause hypoestrogenemia. Postmenopausal women who are on aromatase inhibitors, and any postmenopausal woman who has an indication to screen for osteoporosis as per your local guidelines. So here we use the Canadian osteoporosis screening guidelines, and we have a number of indications to screen in postmenopausal women who don't have necessarily, who are not, on aromatase inhibitors or breast cancer treatment related causes. So there are a number of indications, but there are different guidelines, and feel free to use your own local guidelines or North American guidelines or European guidelines. Just to remind you, the FRAX tool is a fracture risk assessment tool that we also use to assess the risk of fracture for patients who have bone osteopenia or osteoporosis. And although it's not necessarily validated in the breast cancer population, but it's still a helpful tool if you're not really sure whether or not this patient requires treatment with bone modifying agents. It's very important that you use your patient population. So actually you can just go to the tool and choose the country. So here I chose Palestine. So when you're applying it to your patient population, make sure you choose the right country. And then it's a pretty easy tool to just populate the patient data. And then it will come out with a score that helps you at least decide whether or not the benefits of giving bone modifying agents outweigh the risks. So if these patients have the risk of having a hip fracture more than 3% and major osteoporotic fracture more than 10%, that's actually high risk and indicates starting anti-resorptive agents. In terms of management, so pharmacological management and non-pharmacological management are very important. So for patients who have breast cancer due to a treatment-related loss or metastases that I will be focusing on, as this is the purpose of this talk, there are really two groups of agents that are evidence-based and approved is the bisphosphonates and the rank ligand inhibitor denosumab. It's very important that patients still take enough calcium in their diet because you need that for mineralization. So 1200 milligrams of elemental calcium, which you want that from both diet and supplements. So if the patient takes 4 to 5 servings of dairy products and calcium containing food, that comes out to 1200, you probably don't need to add calcium supplements. Vitamin D is very important to keep their 25-hydroxy vitamin D level between 75 and 125 nanomole per liter. It's very important to counsel about fall prevention, bone strengthening exercises that the patient can do within their abilities. So yoga is very good, aqua, and any sort of exercise that will strengthen their bones. And if your patient is a smoker, it's very important that you counsel them about smoking cessation. I'm going to focus on bone modifying agents. So bisphosphonate essentially inhibit activated osteoclasts. So it tries to reduce the excess osteoclastic activity in this patient population. So prevent further bone resorption and bone loss, and hopefully increasing bone formation. Denosumab is one of the monoclonal antibodies that actually inhibits rank ligand from binding to its receptors on the osteoclast. Again, the same idea, preventing further osteoclastic activity and bone loss. The treatment regime actually differs whether it's treatment-related bone loss or metastases-related. So for treatment-related bone loss, as you can see here, the choices that are being studied in large randomized controlled trials for bisphosphonates is either the IV bisphosphonates, which include zoledronic acid, 4 milligram intravenously every 6 months, or pamidronate 60 milligram intravenously every 6 months. As you can see, this is different than the dose that we would give for patients who have just, osteoporosis from just being postmenopause, where we give 5 milligram every 1 to 2 years, and even now more recent studies showing that it can be protective up to 5 years. So it's more frequent in this patient population just because they really have way higher risk given the treatment that really deplete their estrogen, in addition to having breast cancer. If your patient is not interested in intravenous option, oral is there. So rosedronate 35 milligram but daily, and alendronate 70 milligram daily. If they chose to go with denosumab, it's 60 milligram every 6 months, so kind of similar to the usual regime. We know from studies that these agents at those dosages will increase your bone mineral density, will prevent further bone loss, and will reduce the risk of fragility fracture. Whether or not you want to use the bone turnover markers to guide your treatment is up to you, because there have been mixed results, and some showing that they do help and some showing that they don't help. At my center, we don't really use bone turnover marker because it doesn't really change management. If patients have bone metastases and they're resulting in more bone loss and fragility fracture, the treatments becomes more aggressive. So usually we use, as you can see here, 4 milligram of IV zoledronic acid every 4 weeks instead of every 6 months, or pamidronate 90 milligram every, again, 3 to 4 weeks, or denosumab 120, so double the dose every month. So these are pretty high doses. But these, in the randomized trials, shown that they do reverse or stabilize bone loss from metastases and reduce the risk of all these skeletal-related adverse events in patients who have breast cancer metastases. Whether or not you want to prescribe those dosages for patients who have metastases to their liver, to their brain from breast cancer, but not yet bone, is unclear, but you could consider it if they have osteopenia or osteoporosis, but we're not sure if that will actually reduce the risk of fractures or bone mets if they didn't have it yet, but they have mets elsewhere. What about those who progress while being on bone modifying agent? Again, we still don't have good trials to say switching from one bisphosphonate to another makes a difference. But some centers and some oncologists, based on expert opinion and small cohort studies, shown that actually when patients progress while being on bisphosphonate, switching to denosumab might have better efficacy. But again, you follow your center guidelines and your local practices, because there's not really good evidence. It's very important that we always think about side effects that result from these agents. So common and manageable side effects include arthralgias, fever, bone pain, fatigue, tiredness, all of which happen in the first few days after taking the treatment, but they tend to resolve with Tylenol and rest. The rare side effect is atypical femur fractures, and that's why it's very important to counsel your patient if they have any deep thigh pain, that you seek medical attention by getting bilateral femur x-rays, and assessment by a physician. Osteonecrosis of the jaw is a concern, especially in the cancer population. That's why patients need preventative densitometry and get all their procedure done before we start on bisphosphonates. And very important that we monitor their calcium level, their renal function, and vitamin D level, because they are at risk of hypocalcemia. Essentially, bone loss is very common in patients who have breast cancer, whether it's treatment-related or metastasis-related. And we know bone-modifying agents have been shown to reverse or stabilize bone loss, along with other bone preventative strategies. But we still need more studies to assess the ideal time to initiate therapy, duration, and modification. Thank you very much for listening. These are just references for your read. And I appreciate you listening to me. If you have any questions, please email me. I would have loved to be with you today. This is just to show you me at the top of Mountain Garibaldi in BC and carrying the kufiya as a proud Palestinian. Thanks.